Next speaker, who is Dr. Geetha Iyer from Shankar Nethralaya, Chennai, on different case scenarios in mucous membrane pemphigoid.
Good evening, everyone. I think after those excellent talks on the pathophysiology, the diagnosis and management, I will be sharing some of the cases that we have handled of mucous membrane pemphigoid. So I would be speaking on cases that have been positive, biopsy negative. I will compare and contrast some cases of other AIBDs, and then finally focus on cases that have had surface stabilization and phonics reconstructive procedures and visual rehabilitative procedures, and focus on some of these issues that we see commonly in our clinics: the age at presentation, asymmetric presentation, the choice of immunomodulation, what happens when you discontinue the immunomodulation, the relevance of history in a non-AIBD diagnosis, the OCP, Sjogren's syndrome, tussle, presence of lid margin keratinization in these patients, surface stabilization procedures, and visual rehabilitation. So let's go straight into our first case, the 32-year-old male who presented with sudden onset redness, ulceration, hoarseness of voice, laryngeal lesions, and oral ulcerations over a period of 6 months. He was already diagnosed as MMP. Biopsy of the oral mucosa had already been performed by the dermatologists. He had been started on mycophenolate 2 grams a day with systemic steroids by the time he came to us. This was the presentation where there was still ulceration and inflammation in the eye. And subsequently, when the systemic steroids were being tapered, he had an exacerbation, at which point in time the option of rituximab was being contemplated, but the patient stabilized with increasing the systemic steroids and with continued mycophenolate. We now have a close to 2.5-year follow-up. He still continues to be on the mycophenolate 2 grams a day, and the condition remains stable as of now. The highlight of this case is that this is a young patient. Normally, when we talk about MMP, we say that it's a disease that usually manifests in the 60s, but this was a patient who was relatively young and is currently being well managed and under control. This was an elderly patient who presented with diffuse ulceration and inflammation in both the eyes. Though he gave no history of oral lesions, he had an active oral ulceration. Now, we in fact went ahead and biopsied both from the oral mucosa and the conjunctiva, and it was the conjunctival biopsy which turned out to be positive for MMP. Considering the severe inflammation and the bilaterality of the condition, this was a patient we pulsed with endoxin. He's received 2 doses of endoxin now, and we are maintaining him on mycophenolate 1 gram per day along with systemic steroids in the initial period. This was an elderly female, well educated. We had a strong clinical suspicion of OCP in this patient considering the cicatricial changes. Her biopsy was negative. We had seen her in 2016, started her on mycophenolate. She was under our care for 1.5 years, but then after that, she refused to continue the mycophenolate despite the risks of discontinuing it being explained, and she also discontinued her follow-up. She was referred back to us 1.5 years back with worsening when she came with an infection and severe worsening of cicatrization in both the eyes. We restarted the systemic steroids and mycophenolate after healing of the infection, and this was how she quietened. Following her presentation after the exacerbation, we had no other choice but to go ahead with a Boston type 2 keratoprosthesis in her left eye. And she got back a vision of 20/20, but it's a long journey that needs to be followed up. And she's currently on mycophenolate, continuing the systemic immunosuppression. So this case highlights the risk of discontinuing immunomodulation in these patients, and they can really come back to you with a very severe worsening. This was an elderly female who was earlier being treated for breast malignancy. She was referred to us, diagnosed as MMP, and this was how she presented to us in 2018. It was strictly unilateral. The other eye was absolutely normal. She had other mucosal lesions. The dermatologists had labeled her as MMP, and she continues to be on mycophenolate. And this is how she came back to us in 2021. That eye has completely keratinized. She'd had a conjunctival biopsy done in between elsewhere, which was negative. The oral mucosal biopsy was negative, but she continues to be on mycophenolate, and the other eye continues to remain uninvolved at this point in time. This was a patient who was grossly asymmetric features and a unilateral presentation. Now, we do have other AIBDs that can present with conjunctival ulceration, but usually don't leave back a scarring. This was a diagnosed patient of bullous pemphigoid where there's absolutely no cicatricial changes that you see in these patients. Similarly, patients of pemphigus vulgaris also, despite their extensive ocular involvement, do not usually show any signs of cicatrization or scarring. And these patients usually have skin lesions that are more prominent than their ocular involvement. And the absence of cicatrization is something that compares and contrasts with OCP. This was a patient who was elderly female being treated for dryness as primary Sjogren's, and she was only on lubricants and hydroxychloroquine, if I'm not wrong. But careful examination revealed punctal stenosis, medial canthal keratinization. There were no other cicatricial changes. I just happened to examine her mouth, and this was the lesion that her tongue showed up. And when we referred her to the dermatologist, the biopsy turned out to be erosive lichen planus, and she was started on tablet mycophenolate. Similarly, this was another patient whom we clinically thought was MMP, but her biopsy revealed it to be linear IgA disease, and this patient was started on tablet Dapsone. So these are some of the other AIBDs that are associated with conjunctival scarring, and they can mimic your MMP, but usually seeing these in isolation just in the eye like MMP is usually very, very rare. Now, this was a patient who had been diagnosed as OCP elsewhere. The biopsy had been done twice elsewhere. It was negative. She'd been started on mycophenolate. She had been started on cyclophosphamide, and there was no change in her dryness. She had dryness in one eye and cicatricial changes in both the eyes. She presented to us with a non-healing epithelial defect with microperforation that required a tissue adhesive and bandage contact lens. We revisited her history and realized that her dryness had started 2 years back following a severe episode of conjunctivitis where all family members had been affected, prior to which she was absolutely normal. We diagnosed her as post-conjunctivitis cicatrization related dry eye and did a punctal cautery for her. She's also been under a follow-up with us for almost 2 years now, only on topical lubricants with no progression of cicatrization, and she's absolutely stable and symptomatically comfortable at this point in time. So history taking is something that does sometimes reveal important aspects that might give a clue to diagnosis in these patients. Moving on to phonics reconstructive and surface stabilization procedures. This was a patient who the other eye was keratinized, and in this she was hardly self-ambulatory with the vision that she had in this eye. We went ahead, formed the phonics, did a mucous membrane grafting on the palpebral surface, and the better form phonesis now helped us fit her with the PROS lenses, and she now has a vision of 20/80. She still continues the tablet mycophenolate to control her disease activity. In all the MMP patients that we have seen thus far, this probably was the only patient that had lid margin keratinization, which usually we see more commonly in patients of Stevens-Johnson syndrome. And this patient, again, underwent mucous membrane grafting for LMK under systemic steroid and immunosuppressive cover. And you can see the improvement in the surface post the procedure. For visual rehabilitation, in a few cases, we have resorted to performing the alloslet procedure. But this is something that we have limited to only moist eyes under immunosuppressive cover with a relatively clear underlying cornea that does not require a lamellar or a penetrating keratoplasty. We have quite a few patients for whom we have done this procedure who are doing well, but it does have its cons. And these are patients who have to be under very close follow-up, since they can end up having issues of non-healing epithelial defects and the issues related to the same. Just to highlight this one case, which had significant ups and downs, this is how the patient presented to us with severe dry eye, ulceration, and cicatrization in one eye, and a significant subconjunctival fibrosis in both the eyes. This was a patient who subsequently worsened drastically. Despite being on mycophenolate and systemic steroids initially, this was a patient who received IV rituximab, after which we did an alloslet for him in one eye, and subsequently that also failed. This was under the mycophenolate immunosuppression. This is how it subsequently failed. We then started this patient on tacrolimus. The eye quietened down. We've subsequently gone ahead and done an alloslet along with the cataract surgery. And for almost a period of close to a year now, just received his photograph on the phone last week, continues to remain like this. And he continues to be stable with systemic tacrolimus in this patient. So this was just to highlight one struggling case that we have had. Moving on to keratoprosthesis, Professor Girling mentioned about the various K-pros that are available. This was a patient for whom we had initially done LK with a limbal allograft. She was on mycophenolate, but subsequently her graft failed. We did a type 1 keratoprosthesis for her because otherwise the eye was relatively moist, and she continues to maintain that K-pro in her eye now 5 years down the line, though she did have a carrier graft melt in 2019, for which I did an annular lamellar graft, and she continues to be on tablet mycophenolate to keep her disease under control. This was another patient where we did attempt to do an alloslet. The other eye was absolutely keratinized, but the area which had perforated initially when he presented did end up having an issue postoperatively, and we had to finally take him up for a Boston type 2 keratoprosthesis, and he continues to maintain a vision of 6/9 in that eye with a more than 3 year follow-up now. The OKP is our go-to procedure in these patients with very severe ocular surface keratinization when the tooth is available as an option. And our experience with K-pros in MMP has been 9 K-pros thus far, 1 type 1, 5 type 2s, and 3 OKPs. And our learning has been a long journey. I mean, it includes several aspects beyond what meets the eye. We've learned that careful history taking is very crucial. We require the constant support of a dermatologist and immunologist, and building a rapport with the patient is extremely important. Our experience in the last 4 years has been of close to 70 patients, where we've done the biopsy in 30 patients, positive in 11 patients, and almost 52 patients are on tablet mycophenolate, which is something that really seems to work in our hands. I would like to acknowledge the team that works in the ocular surface clinic at Shankar Nethralaya. Thank you.